Welcome, everyone, to the Deep Dive. Today, we're plunging into one of the most incredible, often taken for granted balances our bodies maintain. Blood fluidity. Think about it for a moment. Your blood needs to flow absolutely freely through miles of intricate vessels every second of every day, delivering oxygen and nutrients, clearing waste. It's the highway of life.
Absolutely.
Yet the instant you get a tiny cut, that same blood needs to clot, instantly and effectively, to prevent catastrophic bleeding. It's an engineering marvel, isn't it?
It truly is.
Just consider that astounding complexity for something we rarely even consciously acknowledge.
It truly is a marvel, and the stakes couldn't be higher. When this delicate balance is disrupted, you face incredibly dangerous consequences.
Right.
On one side, there's thrombosis, the formation of dangerous, unwanted blood clots that can block vital arteries or veins, leading to, heart attacks, strokes, or pulmonary embolisms. On the other side, you risk uncontrolled bleeding or hemorrhage, which can obviously be life-threatening.
Yep.
So, our mission today in this deep dive is to precisely understand the intricate, interlocking mechanisms governing this blood fluidity, and then to truly master the powerful pharmaceutical interventions used to manage them when that balance falters.
Okay.
We've pulled from an extensive array of sources for this deep dive, from detailed pharmacology texts that illuminate molecular interactions to comprehensive clinical guidelines on how these drugs are actually used in practice. We're going to explore this topic as if you were, an elite professional in this field, building a truly comprehensive understanding.
That's right. We're talking about a masterclass here, going beyond just blood thinners. It's about grasping a sophisticated dance of proteins, enzymes, and cellular components, and how modern medicine steps in when the rhythm goes off. We're going to break down these complex concepts into digestible insights, connecting back to why this intricate understanding truly matters to you. Whether you're curious about human biology, prepping for a meeting, or just want to truly grasp how your body works. Okay, let's unpack this fundamental process. Haemostasis. This is the body's natural built-in system designed to stop bleeding from a damaged vessel. It's not just one isolated event, but a beautifully choreographed sequence, almost like a meticulously planned emergency response.
Precisely. Hemostasis relies on three core pillars working in concert. The first is platelet function, which are the immediate responders to injury.
Okay, the first responders.
Yeah. Imagine your blood vessel as a perfectly smooth tube. When it's damaged, the inner lining, the endothelium, breaks, exposing underlying structures like collagen and a sticky protein called von Willebrand factor, or VWF.
Ah, okay, stuff that's normally hidden.
Exactly. Platelets circulating in the blood quickly sense this exposure and rapidly adhere to these exposed macromolecules at the injury site. This initial adhesion is the crucial first step.
So they're like tiny biological scouts sticking to the damaged wall, initiating the alarm.
That's a great way to think about it.
Yeah.
Once adhered, these platelets become activated. This isn't a passive event. These adherent platelets then undergo a transformation and release a variety of potent signaling substances.
Okay.
Key among these are ADP, or adenosine diphosphate, and thromboxane A2, or TXA2.
Right.
These released substances act as powerful chemical messengers, activating other nearby platelets and recruiting them to the injury site, effectively amplifying the response in a rapid, localized call for backup.
And this leads to what's called the primary hemostatic plug, right?
That's correct. As more platelets are activated and recruited, they aggregate together, forming this initial temporary plug, a soft seal over the wound.
Temporary fix.
Sort of, yes. To give you a conceptual picture, imagine platelets have specific surface receptors like GPVI and GPI that are designed to bind to collagen and von Willebrand factor, mediating that initial stickiness.
Got it.
Then, for activation and aggregation, other crucial receptors come into play. For instance, PAR1 and PR4 respond to thrombin, while P2Y1 and P2Y12 respond to ADP.
So different signals activate different receptors.
Precisely. When these receptors are stimulated, they trigger internal signaling pathways that activate other critical proteins like GPI bialia and COX1. We mentioned TXO earlier. It's a major product of COX1 in platelets and a potent activator of other platelets, creating a positive feedback loop.
Ah, so it keeps the process going locally.
Exactly. And it's fascinating how endothelial cells, which line healthy vessels, simultaneously release prostacyclin, or PGI2, which acts as an inhibitory signal to prevent excessive platelet activation in healthy areas, maintaining a remarkable local control system.
A built-in brake right next to the accelerator.
You could say that. Now, the second pillar enabler is blood coagulation, often called the coagulation cascade. While platelets are forming that initial plug, the vessel wall injury simultaneously exposes something called tissue factor, or TF. This protein is normally tucked away, not present on blood-contacting cells, but when the vessel wall is damaged, TF is literally unfurled, signaling injury. This exposure of tissue factor is what truly kicks off the entire coagulation system.
So tissue factor is the ignition switch for the whole clotting cascade.
It is, yeah. And activated platelets don't just form a plug, they also supercharge this coagulation system. They provide a vital, negatively charged surface onto which clotting factors can assemble, greatly increasing their efficiency.
Right, like a platform.
Exactly, a platform. They also release stored clotting factors, adding to the pool. All of this leads to a rapid surge or burst of thrombin generation.
Thrombin, that's a key player, right?
Absolutely central. Thrombin, also known as factor Ia, is the central protease in the system.
Yeah.
It has multiple critical roles. It converts soluble fibrinogen into insoluble fibrin strands, which is the structural backbone of the clot.
The mesh.
The mesh, yes. It also acts as a powerful activator of more platelets, feeding back into that initial platelet plug formation. And perhaps most crucially, it promotes more thrombin generation in a powerful positive feedback loop.
So it's not just a product, but also an accelerator for its own creation and for platelet action. That sounds incredibly efficient, but also potentially dangerous if not tightly controlled.
Absolutely. It's all about balance. The end result of this thrombin burst is the formation of robust fibrin. These insoluble fibrin strands interlace and stabilize the platelet aggregates, essentially weaving a strong, durable mesh that forms the definitive, robust clot.
Making that temporary plug permanent.
Exactly. This entire process involves a series of zymogen activation reactions where inactive precursor proteins are converted to active proteases by precise cleavage. Thrombin is often considered the final protease generated in this complex chain of reactions, but its role extends far beyond just that final step.
Okay, so let's talk about these pathways, extrinsic and intrinsic.
That's right. Now let's delve into the pathways of coagulation, which can often seem quite complex but are elegantly designed. Traditionally, we talk about two main pathways, the extrinsic and the intrinsic.
The extrinsic sounds like it starts from outside the blood, external to the factors all circulating in the plasma, right?
That's a good way to think of it. The extrinsic pathway is initiated by tissue factor, or TF, exposed at sites of vessel wall injury. A small amount of circulating factor VA, which is factor 7 that has already been activated, binds to this exposed TF. When factor VA is bound to TF in the presence of anionic phospholipids and calcium ions, its activity is dramatically amplified, like 30,000-fold.
Wow.
This TF factor VA complex then activates factors X and IX, setting the cascade in motion. This complex is often called the extrinsic tenese because it activates factor X tenase.
So it's a quick, powerful starter when there's direct vessel damage. What about the intrinsic pathway? Does it mean the factors are all contained within the blood itself?
Historically, yes, that's where the name came from. The intrinsic pathway was originally described as being initiated in a test tube by contact with negatively charged surfaces like glass. In this artificial setting, factors 12, prekallikrein, and high molecular weight kinagen interact to kick off the chain.
Okay. In the lab, but in the body.
Right, that's the key distinction. If we connect this to the bigger picture in clinical reality, the intrinsic pathway in vivo, meaning within the living body, is activated by things like contact of blood with medical devices, think mechanical heart valves or bypass circuits.
Ah, okay.
It can also be activated by components released during inflammation, like cell-free DNA or structures called neutrophil extracellular traps, even inorganic polyphosphates.
Interesting. So not just physical damage.
Correct. Once activated, factor SOI activates factor OIS, and the resultant factor OI then activates factor IX. Factor ISA then activates factor X in a reaction that is greatly accelerated by factor 8O, those anionic phospholipids we mentioned, and calcium.
Another tenese.
Exactly. This entire complex is known as the intrinsic tenese, and it's crucial because it activates factor X much more efficiently than the extrinsic pathway alone. Optimal thrombin generation really depends on this intrinsic tenese complex for massive amplification.
This raises an important question. If these pathways are so critical, what happens if you're deficient in one of these factors? Does it always lead to severe bleeding?
That's a great point, and it brings us to the clinical relevance of pathway deficiencies. Surprisingly, a deficiency in factor 12, prekallikrein, or high molecular weight kinagen all key players in the intrinsic pathways initiation, does not typically cause excessive bleeding.
Really? Why not?
It suggests a redundancy or perhaps alternative activation mechanisms in vivo. However, factor XI deficiency does result in a variable and usually mild bleeding disorder. Critically, though, congenital deficiencies of factor VIII or factor IX lead to severe hemophilia A or B, respectively. These are associated with spontaneous, often severe, and potentially fatal bleeding, underscoring the vital role of these factors, especially AIA and IXA, in amplifying thrombin generation.
Right, hemophilia. That highlights their importance.
Absolutely. Moving to the structure of coagulation factors, factors 2, prothrombin, 7, 9, X, AF, and 12 are all zymogens, meaning they are inactive precursors that become active proteases upon cleavage.
Zymogens, inactive precursors. Got it.
A key structural feature is the presence of specialized gamma-carboxyglutamic acid, or GLA, residues near their amino termini, particularly in factors 2, 7, 9, and X.
All residues.
Yes. These GLA residues are crucial because they bind calcium, enabling these proteins to interact effectively with the negatively charged phospholipid membrane of activated platelets. This membrane acts as a scaffold, bringing all the components together for efficient clotting.
So these GLA residues are like little hooks that allow the factors to dock onto the platelet surface, making the reactions much more efficient.
Exactly. Nicely put. And beyond the zymogens, we also have non-enzymatic protein cofactors. Tissue factor, factor V, and factor VIII. Tissue factor, as we discussed, is a lipoprotein cofactor that initiates coagulation when exposed by vessel damage, dramatically enhancing factor A's catalytic efficiency.
Right.
Factors V and VIII circulate as procofactors. Thrombin plays a crucial role in activating them. It releases von Willebrand factor from factor VIII and activates both factor V and factor VIII, yielding factors VA and ADA.
So thrombin activates its own helpers too.
Yes, another feedback loop. Once activated, these cofactors bind to the surface of activated platelets and act as receptors, bringing their respective enzymatic partners and substrates together, vastly accelerating the coagulation process.
Bringing everyone to the party on the platelet surface.
Precisely. All these steps converge on the activation of prothrombin. Factor Z is the enzyme that converts prothrombin into thrombin by cleaving two specific peptide bonds. This reaction is dramatically enhanced by a complex called the prothrombinase complex.
Prothrombiase. Sounds important.
It is. This complex consists of factor Va, that negatively charged phospholipid surface from activated platelets, and calcium ions. In the presence of this complex, factor Z activates prothrombin with astonishing efficiency, like a billion-fold increase in efficiency.
A billion-fold. Wow.
Yeah. This maximal rate of activation is dependent on prothrombin and factor Z having those GLA residues we discussed, which allow them to bind calcium and interact with the anionic phospholipid surface. This is where precision meets power in the cascade.
So this prothrombinase complex is like the ultimate amplification stage, ensuring a huge burst of thrombin precisely when and where it's needed.
That's it. And once the clot has done its job, typically as wound healing progresses, the body needs to remove it to restore normal blood flow and prevent obstruction. This brings us to the third core pillar, fibrinolysis, or clot removal.
So this is the cleanup crew dissolving the clot once it's no longer needed.
Precisely. Fibrinolysis is the pathway of clot removal, dissolving intravascular fibrin through the action of an enzyme called plasmin.
Plasmin.
Right. Plasmin is generated from its inactive precursor, plasminogen, through the action of plasminogen activators. The two main activators are tissue plasminogen activator, or TPA, and urokinase plasminogen activator, or UPA.
TPA and UPA.
Both convert inactive single-chain plasminogen into active two-chain plasmin. While both are synthesized by endothelial cells, TPA predominates for intravascular fibrinolysis, meaning dissolving clots inside blood vessels, while UPA largely handles extravascular fibrinolysis, perhaps in tissues.
Okay, different jobs, basically.
Essentially. The regulation of fibrinolysis is tightly controlled to ensure unwanted thrombi are removed, but the fibrin in healthy wounds is preserved. Endothelial cells release TPA, but circulating TPA is rapidly cleared from the blood or inhibited by specific plasminogen activator inhibitors, particularly PAI-1.
PAI-1, an inhibitor.
Yes. This ensures that TPA has little effect on circulating plasminogen when there's no fibrin around. What's fascinating is that TPA's catalytic efficiency in activating plasminogen increases dramatically, like 300-fold in the presence of fibrin.
So it becomes much more active on the clot itself.
Exactly. This promotes localized plasmin generation right on the clot surface, like a smart bomb targeting just the fibrin.
Clever.
Very. Plasminogen and plasmin both bind to specific lysine residues on fibrin via structures called Kringle domains. This binding to fibrin is key because it protects plasmin from inactivation.
Protects it from what?
Normally, a plasma protein called alpha-2 antiplasmin, or A2AP, rapidly inactivates any free plasmin circulating around. But when plasmin is bound to fibrin, it's shielded from A2AP, allowing it to efficiently digest the fibrin.
Ah, okay, so binding keeps it safe to do its job.
Right. As the fibrin clot degrades and plasmin is released, A2AP can then rapidly inactivate any escaping plasmin, preventing widespread degradation of other important coagulation factors. There's even a mechanism where factor 30 helps cross-link small amounts of A2 antiplasmin directly onto the fibrin, further preventing premature clot lysis.
So it's a sophisticated system that ensures the clot is broken down from the inside out, and only when and where it's truly needed. This immediately makes me think of therapeutic application.
Exactly. This detailed understanding directly leads to therapeutic implications. When thrombi dangerously occlude major arteries or veins, like in a heart attack or stroke, therapeutic doses of these plasminogen activators, known as fibrinolytic agents, can be administered.
The clot busters.
That's the common term, yes. The goal is to rapidly degrade the fibrin and restore blood flow. However, it's a delicate balance. At high doses, these agents can overwhelm the body's natural inhibitory controls, meaning plasmin, being a relatively nonspecific protease, can then start to degrade other coagulation factors beyond just fibrinogen, such as factors V and A. This reduction in coagulation proteins impairs the capacity for thrombin generation, which can significantly increase the risk of bleeding.
Right. It's not just dissolving the bad clot.
Correct. Furthermore, unopposed plasmin can also dissolve fibrin in the hemostatic plugs that are maintaining integrity at other healthy vascular injury sites, further increasing the risk of hemorrhage. So bleeding is the major side effect of these powerful drugs.
Makes sense. And how do we check all this in the clinic? The lab tests?
Yes. To tie this all back to how we assess coagulation in a clinical setting, we use coagulation in vitro lab tests. These tests essentially mimic parts of the coagulation process to measure clotting times. For example, whole blood normally clots in about 4 to 8 minutes in a glass tube. The contact of blood with glass activates factor 12, initiating coagulation via the intrinsic pathway.
Okay.
Adding a chelating agent like EDTA or citrate prevents clotting by binding calcium, which is essential for coagulation.
So calcium's a bottleneck for clotting, and removing it stops the process. Makes sense. What about the common tests we hear about, like APTT and PT?
Right. The activated partial thromboplastin time, or APTT, is a widely used test. It measures the clotting time after recalcified plasma has been exposed to negatively charged phospholipids and particulate activators like silica or kaolin. This test primarily reflects the integrity of the intrinsic and common coagulation pathways.
Intrinsic and common.
Okay. Then there's the prothrombin time, or PT, which measures clotting time after the addition of thromboplastin, a mixture of tissue factor and phospholipid along with calcium. This test primarily reflects the extrinsic and common pathways.
Extrinsic and common.
Got it. These tests are vital for diagnosing bleeding disorders, monitoring anticoagulant therapy, and assessing overall hemostatic function.
Here's where it gets really interesting. Our bodies don't just know how to clot when injured. They also have powerful natural brakes, built-in anticoagulant mechanisms to prevent unwanted clotting in healthy vessels.
That's a crucial point. Thrombosis is actively prevented by several regulatory mechanisms that rely on a healthy vascular endothelium, the lining of your blood vessels. This healthy vascular endothelium is the primary defense.
How so?
Well, it synthesizes and releases substances like nitric oxide and prostacyclin, both of which inhibit platelet activation. Furthermore, endothelial cells express CD39, an enzyme that degrades ADP and ATP, which are key platelet activators, thereby preventing platelet aggregation.
So the healthy lining itself keeps things calm.
Exactly. Then we have a crucial plasma protein called antithrombin. This protein inhibits several activated coagulation enzymes, particularly thrombin and factor ZA.
Antithrombin against thrombin. Makes sense.
And what's fascinating here is that heparan sulfate proteoglycans, which are synthesized by endothelial cells, dramatically enhance the activity of antithrombin, speeding up its ability to inhibit clotting factors by 1,000-fold.
So antithrombin is like a vigilant patrol car, and heparin sulfate gives it a super boost.
And a great analogy. It makes antithrombin incredibly efficient at neutralizing rogue clotting factors before they can cause trouble. Another vital system is the protein C system. Protein C is a plasma zymogen that becomes active when thrombin binds to thrombomodulin on the endothelial cell surface.
Thrombin again, but doing something different here.
Yes, thrombin has multiple roles. This thrombin-thrombomodulin complex then activates protein C. The activated protein C then, with its cofactor protein S, degrades factors Va and Eta.
And what's the consequence of degrading factors Va and Eta?
By degrading these critical cofactors, the activated protein C system greatly diminishes the rates of prothrombin and factor X activation, effectively attenuating thrombin generation. This is a powerful natural brake.
Another brake system.
Indeed. The clinical link here is significant. A deficiency of either protein C or protein S is strongly associated with an increased risk of venous thrombosis, underscoring their importance in preventing clots.
Wow. So deficiencies there lead to more clotting.
Correct. Finally, we have tissue factor pathway inhibitor, or TFPI. This is another natural anticoagulant found in the lipoprotein fraction of plasma or bound to endothelial cell surfaces.
TFPI, related to tissue factor.
Yes. TFPI works by first binding to and inhibiting factor ZAG. This complex then, in turn, inhibits factor VIA that is bound to tissue factor. So in a clever feedback loop, factor ZAG actually regulates its own generation through TFPI, providing another layer of control to prevent excessive clotting.
Fascinating. It inhibits the thing that started it all.
In a way, yes. These natural mechanisms are constantly at work, maintaining that delicate balance we talked about.
So what does this all mean for intervention? When the body's natural balance falters, that's precisely where antithrombotic drugs come into play.
Exactly.
We have three main categories in this powerful arsenal. Antiplatelet drugs, which target platelet function, anticoagulants, which attenuate fibrin formation, and fibrinolytic agents, which actively degrade existing fibrin clots.
It's crucial to remember the inherent trade-off with all of these medications. While they are designed to prevent dangerous clots or break them down, all antithrombotic drugs, by their very nature, increase the risk of bleeding.
Right, that's the flip side.
It's a fundamental consideration in their use and a core part of mastering the application of these drugs. We'll delve into each category now, starting with those given parenterally, typically in a hospital setting. Hashtag A, parenteral anticoagulants.
Let's start with the workhorses of the hospital setting. Heparin and its relatives. These are often the first line of defense, aren't they?
Indeed. Unfractionated heparin, or UFH, is a foundational anticoagulant. It's a complex sugar chain, a glycosaminoglycan found naturally in mast cells and commercially extracted, usually from porcine intestinal mucosa. Its activity is standardized using USP or international units to ensure consistent dosing.
Unfractionated, meaning it's a mix of different sizes.
Precisely, a mix of chain lengths. A key point is that heparin itself has no intrinsic anticoagulant activity. Its power comes from its ability to bind to and accelerate the action of antithrombin, that natural inhibitor we discussed.
Okay, it boosts antithrombin.
Exactly. Antithrombin inhibits activated coagulation factors, especially thrombin and factor ZA. Heparin binds to antithrombin via a very specific pentasaccharide sequence within its structure. This binding induces a crucial conformational change in antithrombin, making its reactive site much more accessible to the target proteases, dramatically accelerating factor ZA inhibition by maybe 2 orders of magnitude. Now, for thrombin inhibition, it's slightly different. Heparin acts as a catalytic template, bridging antithrombin and thrombin together. This bridging function requires heparin molecules of a certain length, 18 or more saccharide units.
So longer chains are needed to bridge thrombin.
Correct. Unfractionated heparin has enough long chains to do this effectively, which is why it catalyzes the inhibition of both factor ZA and thrombin to a similar extent, roughly a 1.1 ratio.
That's catalytic.
Yes, it acts in a truly catalytic fashion. After facilitating the antithrombin protease complex, the heparin molecule dissociates and is free to catalyze other antithrombin molecules.
Efficient.
Very. Interestingly, platelet factor 4, released from activated platelets, binds heparin and can actually limit its activity, particularly near platelet-rich thrombi. High doses can also directly interfere with platelet aggregation and prolong bleeding time. Oh, and it also clears lipemic plasma by releasing lipoprotein lipase.
Okay, so where is it used clinically?
From a clinical use perspective, heparin is indispensable for the initial treatment of deep vein thrombosis, DVT, and pulmonary embolism, PE, and for unstable angina or acute myocardial infarction. It's crucial during coronary angioplasty and stent placement.
All right.
For any surgery requiring cardiopulmonary bypass, heparin remains the agent of choice because bypass circuits activate factor 12, which heparin helps manage. It's also used for DIC, disseminated intravascular coagulation, and low-dose subcutaneous heparin is very commonly used for thromboprophylaxis in immobilized medical patients or those undergoing major surgery.
In pregnancy. Safe?
Critically, yes.
Yeah.
UFH, LMWH, and fondaparinux are the drugs of choice during pregnancy as they do not cross the placenta or cause fetal malformations, though typically discontinued about 24 hours before delivery.
Good to know. How is it given and monitored?
Regarding ADME, unfractionated heparin must be given parenterally, typically by continuous intravenous infusion for immediate onset or subcutaneously, which has a delayed onset. Its half-life is dose-dependent, ranging from 1 hour at low doses, maybe up to 8 hours at higher doses, and it's primarily cleared by the reticuloendothelial system.
Okay.
For administration and monitoring, full-dose UFH is usually given by continuous IV infusion, starting with a bolus dose. Therapy is monitored by measuring the activated partial thromboplastin time, or APTT, aiming for a therapeutic range of generally 2 to 3 times the normal value. Daily monitoring until stable.
APTT. Got it.
For very high doses in cardiac surgery, where the APTT becomes essentially infinitely prolonged, the activated clotting time, ACT, is used instead. Subcutaneous doses also aim for a similar APTT target.
What happens if a patient doesn't respond as expected to heparin, like they have heparin resistance?
That's an important clinical scenario. Heparin resistance can occur due to factors like high plasma levels of proteins that compete with antithrombin for heparin binding, or sometimes due to actual antithrombin deficiency.
So what do you do?
Management differs. If it's pseudoresistance, where the anti-factor ZA level is therapeutic but the APT isn't, often due to high factor VIII or fibrinogen, you might not need to adjust the dose. But for true resistance with low anti-ZA and APTT, heparin doses might need to be increased, or in severe antithrombin deficiency, antithrombin concentrate might be necessary. It's worth noting that direct oral anticoagulants, or DOACs, don't require antithrombin, making them a potential alternative in such cases.
Okay, so that's UFH. What about low molecular weight heparins?
Right. Let's detail low molecular weight heparins, LMWH, such as enoxaparin and dalteparin. Their key comparison to UFH is their smaller mean molecular weight, around 5,000 daltons compared to maybe 15,000 for UFH.
Smaller chains.
Exactly. They still bind to antithrombin via that pentasaccharide sequence. But because many LMWH molecules are too short to effectively bridge antithrombin to thrombin, they have greater antifactor ZA activity relative to their antifactor ISA thrombin activity. The ratio is typically around 3.1 to 2.1 anti-ZACA to anti-ISA.
So more focus on factor ZA.
More focused, yes. From a pharmacological effects standpoint, LMWH generally has little effect on platelets and a lower affinity for platelet factor 4, meaning they might retain activity better near platelet-rich thrombi compared to UFH.
And clinically, how are they used?
In clinical use, LMWH has largely replaced UFH for many indications. This is mainly because its predictable pharmacokinetic profile allows for once or twice daily subcutaneous administration in fixed or weight-adjusted doses, typically without the need for routine coagulation monitoring.
No regular blood tests needed mostly. That's a big advantage.
Huge advantage. This makes them ideal for out-of-hospital management of DVTPE and for thromboprophylaxis. However, monitoring is still needed in specific populations, such as patients with significant renal impairment, especially a creatinine clearance less than 30 mmol/min, where it might be contraindicated, also obese patients, pregnant women, and children.
Why renal impairment?
Because LMWH is almost exclusively cleared by the kidneys. Its longer biological half-life, around 4 to 6 hours compared to UFH, can lead to accumulation if kidney function is poor.
Okay, and then there's fondaparinux.
Right. Finally, let's look at fondaparinux. This is a synthetic pentasaccharide. It's essentially just that key 5-sugar sequence found in heparin with a mean molecular weight of about 1,500 daltons.
Just the binding part.
Exactly. Its mechanism is therefore even more specific. It only has anti-factor ZA activity because it is far too short to bridge antithrombin to thrombin at all.
Pure anti-ZA.
Purely indirect anti-AIDS activity. In clinical use, fondaparinux is approved for thromboprophylaxis in major orthopedic surgeries, like hip or knee replacement or hip fracture surgery, and for the initial treatment of DVTPE. It's also significantly less likely to trigger heparin-induced thrombocytopenia, making it a valuable alternative for treating patients with suspected or confirmed HIT.
Useful in HIT then. Any downsides?
Well, it's generally not used for coronary angioplasty due to a reported risk of catheter thrombosis. Its ADME profile includes subcutaneous injection, a peak effect in about 2 hours, and a long half-life of around 17 hours, allowing once daily dosing. Like LMWH, it's excreted almost entirely in the urine, so it is contraindicated in patients with significant renal impairment, again, CRCL less than 30 ml/min, due to accumulation risk, and like LMWH, does not typically require routine monitoring.
With these powerful tools, there's always a flip side, the risk of bleeding. How is that managed, and what are the other serious adverse effects?
You're absolutely right. Bleeding is the major adverse effect of heparin, LMWH, and fondaparinux. The incidence for major bleeding with IV UFH is maybe 1–5%. It's generally lower with LMWH. Often there's an underlying cause like recent surgery, trauma, or concurrent antiplatelet use.
How do you reverse it if needed?
For reversal of bleeding with UFH, its anticoagulant effect disappears within hours of discontinuation. For mild bleeding, often no antagonist is needed. However, in cases of life-threatening hemorrhage, UFH can be rapidly reversed by intravenous infusion of protamine sulfate.
Protamine.
Yes, protamine is a highly basic protein that binds tightly to the acidic heparin, neutralizing its effect. The dose is crucial. Roughly 1 milligram of protamine for every 100 units of heparin estimated to be remaining in the body, given slowly intravenously.
Does it work for LMWH and fondaparinux?
That's a critical point. Protamine only partially reverses the anticoagulant activity of LMWH, mostly neutralizing the anti-IA activity, but less so the anti-azaz, and importantly, it has no effect whatsoever on the anti-AZA activity of fondaparinux.
So no antidote for fondaparinux bleeding.
No specific antidote like protamine. And protamine itself isn't entirely benign. It can have serious adverse effects, including severe hypotension, non-cardiogenic pulmonary edema, and even catastrophic pulmonary vasoconstriction, particularly if given too rapidly or at high doses. Risk factors include previous protamine exposure, fish allergy, and underlying heart or lung issues.
Okay. What about HIT? Heparin-induced thrombocytopenia.
Ah, yes, HIT. This is another serious, potentially life-threatening complication, primarily associated with UFH, less so with LMWH, and rarely with fondaparinux. It's defined by a significant drop in platelet count, usually below 150,000 per microliter, or a 50% decrease from baseline, typically occurring 5 to 10 days after starting heparin.
Just a low platelet count.
Not just that. Paradoxically, the major danger of HIT isn't bleeding, but thrombosis. Up to half of affected patients can experience life-threatening thrombotic complications, like limb gangrene requiring amputation, DVT, PE, even stroke or MI, and these clots may even precede the noticeable drop in platelets.
Clots caused by a drug meant to prevent clots.
It's an immune reaction. The pathophysiology is fascinating. HIT is caused by the development of IgG antibodies against complexes formed between heparin and platelet factor 4, protein released from platelets.
Yeah.
These antibody PF4 heparin complexes then activate platelets, leading to aggregation and thrombus formation, and also platelet clearance, causing the thrombocytopenia.
Wow. How is it managed?
Management of HIT is critical and urgent. If HIT is suspected, heparin or LMWH must be discontinued immediately. The diagnosis can be confirmed with specific laboratory tests like platelet activation assays or immunoassays for the antibodies. Because thrombotic complications can continue or develop even after stopping heparin, an alternative anticoagulant not associated with HIT must be administered promptly.
Like what?
Options include direct thrombin inhibitors like bivalirudin or argatrobin, or sometimes a DOAC like rivaroxaban, or fondaparinux, which has a very low risk of causing HIT. LMWH should definitely be avoided due to cross-reactivity with the HIT antibodies. And it's also crucial that warfarin should not be initiated alone until the platelet count has recovered to normal, as starting warfarin in acute HIT can paradoxically worsen thrombosis, leading to severe complications like venous limb gangrene or skin necrosis.
A very tricky situation. Any other toxicities?
Other toxicities associated with heparinoids include reversible abnormalities of hepatic function tests and osteoporosis with long-term high-dose UFH, though the risk seems lower with LMWH and fondaparinux. Hyperkalemia can also occur due to inhibition of aldosterone synthesis.
Beyond heparin, there are other important parenteral anticoagulants, especially in specific scenarios where heparin might not be suitable or is contraindicated, like HIT.
Indeed. We have a few other parenteral options, mostly direct thrombin inhibitors. Desiredin and loperidin were recombinant forms of heparin, originally from leeches, but they're not available in the U.S. anymore. They were used for HIT.
Okay. What is available?
Bivalirudin is a synthetic polypeptide that directly inhibits thrombin. It's administered intravenously and serves as an important alternative to heparin in patients undergoing coronary angioplasty or cardiopulmonary bypass surgery, especially for those with heparin-induced thrombocytopenia. It has a short half-life, about 25 minutes, and requires dose reductions in patients with renal impairment.
Okay, useful alternative.
Then there's argatrobin. This is a synthetic small molecule reversible thrombin active site binder, also given intravenously. A key difference is that it is metabolized in the liver and excreted in the bile, making it a valuable option for patients with renal impairment, though dose reduction is necessary for significant hepatic insufficiency. Argatromin is licensed specifically for the prophylaxis or treatment of patients with or at risk of developing heparin-induced thrombocytopenia.
So a go-to for HIT, especially with kidney problems.
Exactly. One practical point with argatrobin is that it significantly prolongs the PT and INR, which complicates the transition to warfarin if needed. You might need to use a factor X assay to monitor warfarin in that situation. Hashtag B vitamin K antagonist, warfarin.
Now let's talk about an anticoagulant that has been a cornerstone of oral therapy for decades. Warfarin. It's powerful, but it definitely requires careful, precise management.
Warfarin, yes. Or other vitamin K antagonists like it. They are indeed widely used oral anticoagulants, and their mechanism of action is quite intricate, tying back to those GLAIR residues we mentioned earlier.
Right, the gamma-carboxyglutamic acid thing.
Exactly. Factors 2, prothrombin, 7-IXX, along with the anticoagulant proteins C and S, are all synthesized in the liver as biologically inactive precursors. For these proteins to become functional, they must undergo that crucial post-translational modification called gamma-carboxylation. This reaction requires carbon dioxide, oxygen, and crucially reduced vitamin K.
So vitamin K is like a specialized key that unlocks the activity of these clotting factors.
That's right. This carboxylation reaction is coupled to the oxidation of vitamin K. For sustained carboxylation and continuous synthesis of functional proteins, this oxidized vitamin K must be regenerated back into its reduced form by an enzyme called vitamin K epoxide reductase, VKOR, specifically the VKORC1 subunit.
Okay, a recycling step for vitamin K.
Precisely. And here's where warfarin comes in. Therapeutic doses of warfarin specifically inhibit VKOR, thereby blocking the regeneration of reduced vitamin K and disrupting this cycle.
So it jams the recycling machine.
That's a good way to put it. As a consequence, warfarin decreases the functional amount of these vitamin K-dependent coagulation factors produced by the liver. However, it's vital to understand that warfarin has no effect on the activity of factors already circulating in your blood.
Only stops new functional ones from being made.
Correct. These existing functional factors must be cleared from the circulation before warfarin can exert its full anticoagulant effect. Because some of these factors have relatively long half-lives, factor 2, prothrombin, is the longest at around 50 hours. The full antithrombotic effect of warfarin is not achieved for maybe 4 to 5 days.
That's a long delay.
It is. This delayed onset is why, in patients with acute thrombosis, warfarin must always be overlapped with a rapidly acting parenteral anticoagulant like heparin, LMWH, or fondaparinux.
Right, you need immediate coverage while warfarin kicks in.
Exactly. In terms of ADME, absorption, distribution, metabolism, excretion, warfarin is almost completely bioavailable when given orally, though it can be given RV or rectally too. Food can slow the rate of absorption. Peak plasma levels occur in 2 to 8 hours.
How is it broken down?
It's administered as a racemic mixture of S and R warfarin. S-warfarin is significantly more potent and primarily metabolized by a liver enzyme called CYP2C9. The inactive metabolites are excreted in urine and stool. Its half-life varies widely among individuals, maybe 25 to 60 hours, averaging around 40 hours, and its anticoagulant effect can last for 2 to 5 days after stopping.
I've heard that genetics can play a big role in how someone responds to warfarin. Is that true?
It's absolutely true, and it's a fascinating area of pharmacogenetics and precision medicine. Genetic factors, specifically variations or polymorphisms in 2 key genes, CYP2C9 and VKORC1, account for a large part, maybe most, of the observed variability in warfarin response between individuals.
How do they affect it?
Well, certain CYP2C9 variants result in decreased enzyme activity. This means the S-warfarin isn't metabolized as quickly, leading to higher drug concentrations and thus requiring lower warfarin doses to achieve the target INR.
Okay, slower breakdown means less drug needed.
Right. And certain VKORC1 variants affect how the drug acts on its target enzyme. These variants make the enzyme more susceptible to inhibition by warfarin. So again, patients with these variants need reduced doses. There's a lot of research into using genetic information for precision dosing, though its routine clinical impact compared to careful standard INR monitoring is still being fully established.
Interesting. So where is warfarin typically used?
For its clinical use, warfarin is employed to prevent the progression or recurrence of acute deep vein thrombosis or pulmonary embolism, but always after an initial course of parenteral anticoagulation. It is also highly effective in preventing stroke or systemic embolization in patients with non-valvular atrial fibrillation, those with mechanical heart valves, or certain patients with ventricular assist devices.
So long-term prevention mostly. How is it monitored, the INR?
Exactly. Before starting therapy, a thorough assessment is crucial to rule out any pre-existing bleeding risks like deficiencies, low platelets, liver or kidney issues, or vascular problems. Once therapy begins, the International Normalized Ratio, INR, calculated from the patient's prothrombin time, PT, is used to monitor the extent of anticoagulation.
What's the target INR?
For most indications like DVT, PE, or atrial fibrillation, an INR of 2.0 to 3.0 is the goal. For patients with certain mechanical heart valves, particularly mitral valves or mechanical valves, plus other risk factors like AFib, a higher INR range of 2.5 to 3.5 is often recommended.
And that overlap you mentioned.
Yes, the overlap duration is critical for acute VTE. The parenteral agent, like heparin or LMWH, is typically continued for at least 5 days after starting warfarin therapy, and importantly, it's only stopped when the INR has been measured in the therapeutic range on 2 consecutive days, usually 24 hours apart.
Why so long?
This ensures adequate depletion of all the vitamin K-dependent factors, especially the long-lived factor II, prothrombin, providing true anticoagulation. Initial INR rises are mainly due to factor VII depletion, which has a short half-life.
Got it. How often do you check the INR?
Frequent INR monitoring is needed initially, maybe daily or every few days, until the dose is stable. Once stable, monitoring can usually be extended to every 3 or 4 weeks.
Okay. And typical doses?
The usual initial adult dose is often around 2 to 5 milligrams per day, with subsequent adjustments based on the INR response. Maintenance doses can vary widely, from maybe 1 to 10 milligrams per day or even more. Lower initial doses are often used for elderly patients or those at high bleeding risk.
Now, the interactions sound like a minefield.
They can be complex, yes. Understanding warfarin interactions is absolutely critical for safe use. They can occur through various mechanisms.
Like what?
Altered warfarin absorption or metabolism, changes in vitamin K uptake or metabolism, altered synthesis or clearance of clotting factors, or even things that affect the integrity of epithelial surfaces like the gut lining.
So some things make it less effective.
Right. Reduced efficacy can occur from reduced absorption, like with cholestyramine, or significantly increased hepatic clearance due to drugs that induce the CYP2C9 enzyme. Classic examples are barbiturates, carbamazepine, rifampin. Also, large intakes of vitamin K-rich foods or supplements can counteract warfarin. Pregnancy increases coagulation factors, reducing its effect.
And things that increase bleeding risk.
Yes. Interactions that enhance the hemorrhage risk by increasing warfarin's effect are very common. This can happen through decreased metabolism due to drugs that inhibit CYP2C9, a long list, including amiodarone, azole antifungals, cimetidine, clopidogrel, metronidazole, fluoxetine, and many others.
Wow, lots of common drugs.
Yes. Also, relative vitamin K deficiency due to inadequate diet or broad-spectrum antibiotics eliminating vitamin K synthesizing gut flora can enhance the effect. Impaired liver function, congestive heart failure, or hyperthyroidism can also increase sensitivity.
And some interactions don't even change the INR, but still increase bleeding.
That's a key point. Interactions not altering INR but still raising bleeding risk include things like aspirin and other anti-inflammatory drugs, NSAIDs. They inhibit platelet function and can cause gastritis or ulceration, independently increasing bleeding risk even if the INR is perfectly therapeutic.
Good to remember. What about people super sensitive to warfarin?
Hypersensitivity to warfarin, meaning patients requiring very low doses, like less than 1.5 mg a day, often have those CYP2C9 or VKORC1 genetic variants we discussed. In some cases, low-dose vitamin K supplementation might actually help stabilize their INR control.
Okay, so adverse effects bleeding is the main one.
Yes, the most common and significant adverse effect is bleeding. The risk increases with the intensity and duration of therapy, concomitant drug use, and the presence of an anatomical bleeding source. Major bleeding occurs in maybe less than 3% per year for patients in the INR 2-3 range. Intracranial hemorrhage risk definitely increases with INRs above 4, but importantly, about 2/3 of warfarin-related ICH occurs when the INR is actually within the therapeutic range.
So even a good INR doesn't eliminate risk. How is bleeding managed?
Bleeding management depends on severity. If the INR is high but there's no significant bleeding, you might just hold warfarin and restart at a lower dose later. If the INR is very high, say 10 or more, but still no bleeding, giving a low-dose oral vitamin K1, phytonadione, maybe 2.5 to 5 milligram, can lower the INR over 24-48 hours without causing long-term resistance.
And if the bleeding is serious.
For serious bleeding or profound overdose, the most rapid approach is to restore functional clotting factors immediately. This is best done by administering a 4-factor prothrombin complex concentrate, PCC, which contains factors 2, 7-IX, and X, along with intravenous vitamin K1, maybe 10 milligram. Parenteral vitamin K1 itself carries a small risk of anaphylactoid reactions, especially if given too quickly.
Does giving lots of vitamin K cause problems later?
Yes, high doses of vitamin K1 can make the patient unresponsive or resistant to warfarin for several days, even up to a WINT. If anticoagulation is still needed during that time, you'd have to use heparin, LMWH, or another agent.
Okay. What about pregnancy?
Warfarin is absolutely contraindicated in pregnancy. It crosses the placenta and is a known teratogen causing characteristic birth defects, fetal warfarin syndrome, and abortion, particularly with exposure during the first trimester. Exposure later in pregnancy can cause CNS abnormalities. It also increases the risk of fetal or neonatal hemorrhage, even at therapeutic maternal INR. So heparin, LMWH, or fondaparinux are the safe alternatives.
Crucial point. Any other weird side effects?
Other adverse effects are less common but can be serious. Skin necrosis is a rare complication, typically appearing 3-10 days after starting therapy, often affecting areas with subcutaneous fat like extremities, breasts, or genitals. It's thought to be related to a rapid drop in protein C levels, especially in patients with underlying deficiency or sometimes an HIT. There's also purple toe syndrome, thought to be due to cholesterol emboli. Fatal calciphylaxis or calcium uremic arteriolopathy can occur, especially in patients with kidney disease. Alopecia, urticaria, dermatitis, fever, GI upset are also possible. Hashtags, direct oral anticoagulants, DOAC.
Let's move to the newer generation of oral anticoagulants, often referred to as DOACs, or sometimes NOACs. They offer some significant advantages, particularly in terms of monitoring, which makes them much more convenient for patients and clinicians alike.
That's right. The major convenience of DOACs, direct oral anticoagulants, is that they are generally given in fixed doses and for most patients do not require routine coagulation monitoring, unlike warfarin with its frequent INR checks. This simplicity in management has really revolutionized anticoagulation therapy in many settings.
Big change from warfarin. What types are there?
There are 2 main classes based on their target. First, we have the direct oral thrombin inhibitor, which is Dabicon.
Targeting thrombin directly, how does it work?
Its mechanism is quite direct, as the name suggests. It's actually administered as a prodrug, Dabicon detexilate, which is then rapidly converted in the body to the active form, dabigatran, by plasma esterases. Dabigatran then competitively and reversibly blocks the active site of thrombin.
Blocking thrombin itself.
Yes, and importantly, it blocks both free-floating thrombin and thrombin that is already bound within a clot. By inhibiting thrombin, it effectively prevents the conversion of fibrinogen to fibrin, reduces thrombin-mediated feedback activation of coagulation, and suppresses thrombin-induced platelet activation.
Okay, hits multiple thrombin actions. How is it taken and handled by the body?
Regarding its ADME, dabigatran has relatively low oral bioavailability, around 6%. Peak effects occur about 2 hours after taking it. Its half-life is around 12-14 hours, so it's given twice daily. A crucial point for dosing is that the capsules must be swallowed whole. Opening or crushing them can significantly increase bioavailability and bleeding risk.
Don't crush the capsules, got it. What about elimination?
About 80% of the absorbed dabigatran is excreted unchanged by the kidneys. This renal dependence is really important. A dosage reduction is required for patients with moderate to severe renal impairment, typically a creatinine clearance between 15 and 30 LMN, and is generally contraindicated in those with very poor kidney function, CRCL 15 LMN.
So if renal function is impaired, the drug can build up, increasing bleeding risk.
Yeah.
And what about monitoring, since you mentioned it's generally not needed?
You're right. Its predictable dose-response relationship in most patients is why routine coagulation monitoring isn't necessary. While dabigatran does prolong the APTT, the values tend to plateau at higher doses, making the APTT unreliable for precise monitoring or dose adjustment. It has an unreliable effect on the INR. Specialized tests, like a diluted thrombin time assay, have been developed if quantification is absolutely needed, but that's not routine.
Where is dabigatran used?
For therapeutic uses, dabigatran is licensed for the treatment of acute VTE after an initial 5 days or more of parenteral therapy, for secondary prevention of VTE, and importantly, for stroke prevention in patients with non-valvular atrial fibrillation. It is specifically contraindicated in patients with mechanical heart valves due to unfavorable trial results. Lower doses are used for thromboprophylaxis after knee or hip replacement surgery in some regions.
And the downside's bleeding.
Yes, the major adverse effect, like all anticoagulants, is bleeding. Overall rates of major bleeding in large trials, like for AFib, were similar to warfarin, around 3% per year. However, a significant advantage seen was a markedly reduced risk of intracranial bleeding, maybe by 70% compared to warfarin.
That's a huge benefit.
It is. On the flip side, there appears to be a higher risk of GI bleeding with dabigatran compared to warfarin, particularly in older patients over 75. Bleeding risk is increased with renal impairment and concurrent use of antiplatelets or antivides. Besides mechanical valves, it's also contraindicated in patients with triple-positive antiphospholipid antibody syndrome, where warfarin seems superior.
Any major drug interactions?
Yes, for drug interactions, dabigatran is a substrate for the P-glycoprotein efflux pump. So drugs that inhibit P-glycoprotein, like verapamil, dronedarone, ketoconazole, can increase dabigatran concentrations and bleeding risk, while P-glycoprotein inducers, like rifampicin, can decrease concentrations and efficacy.
Okay, so that's the direct thrombin inhibitor. What about the other class?
Right. The other major class of DOACs are the direct oral factor Bunza inhibitors. This group includes rivaroxaban, apixaban, edoxaban, and previously betrixaban, though that was discontinued.
Targeting factor ZAN instead of thrombin. How do they work?
Their mechanism of action involves selectively inhibiting factor ZA, both free factor ZA circulating in the plasma and factor ZA that's already incorporated into the prothrombinase complex within a clot. By inhibiting factor ZA, they significantly reduce thrombin generation, which in turn suppresses both platelet aggregation and fibrin formation, thus preventing clot development or propagation.
So they're targeting an earlier step in the common pathway compared to dabigatran. How do their ADME and dosing compare to each other? They seem similar, but maybe different.
That's a great distinction to make, as there are important differences in their ADME and dosing. Let's break them down. Rivaroxaban has pretty good oral bioavailability, around 80%, but maximal absorption occurs in the stomach, so the higher doses, 50 milligrams, 20 milligram, should be administered with a meal to ensure adequate absorption. Lower doses don't require food. Peak effect is around 3 hours. The tablet can be crushed if needed. It's highly plasma protein bound. About a third is excreted unchanged in the urine. The rest is metabolized by hepatic enzymes, including CYP3A4, with metabolites excreted in urine and feces. Exposure increases with renal impairment and severe liver dysfunction. A dose reduction is common for patients with moderate renal impairment, CRCL 15 to 50 millimole, and it's generally not used with severe impairment, CRCL 15 millimole. Dosing varies by indication, often starting higher for acute DVT-PE, 15 milligrams twice daily for 21 days, then 20 milligrams once daily, and potentially reducing further for long-term secondary prevention, for example, 10 milligrams once daily after 6 months.
Okay, rivaroxaban with food for higher doses, renal adjustment needed. What about apixaban?
Apixaban has about 50% atal bioavailability. Peak effect is 1 to 3 hours. Importantly, food does not significantly affect its absorption. The tablet can also be crushed. It's about 87% plasma protein bound. Renal clearance accounts for about 27% of elimination. It's also metabolized by hepatic CYP3A4, with metabolites excreted mainly in bile intestines and some in urine. The usual dose for AFib or VTE treatment is 5 milligrams twice daily. However, a dose reduction to 2.5 milligrams twice daily is recommended for AFib patients if they meet 2 out of 3 specific criteria: age 80 years or older, body weight 60 kilograms or less, or serum creatinine 1.5 milligrams or higher. For acute VTE treatment, it started at 10 milligrams twice daily for 7 days, then reduced to 5 milligrams twice daily. For extended secondary prevention, the dose can be further reduced to 2.5 milligrams twice daily.
Apixaban, no food effects, specific dose reduction criteria. And edoxaban.
Edoxaban has about 62% bioavailability, peak effect in 1 to 2 hours. Food also does not affect absorption. It has lower protein binding, around 55%. About 50% is eliminated unchanged in the urine, so renal function is important. It undergoes minimal hepatic metabolism, so liver disease doesn't significantly affect its pharmacodynamics. Exposure is increased by renal impairment, low body weight, and concomitant use of potent P-glycoprotein inhibitors. The standard dose is 60 milligrams once daily, but this is reduced to 30 milligrams once daily for patients with CRCL 15 millimole, body weight 60 kilograms or less, or those taking certain PGP inhibitors. It's contraindicated with CRCL 15 mmN.
Okay, renal dose adjustments for all of them seem common. Any other quirks with edoxaban?
Yes, a notable point for edoxaban specifically in the US is that it is not recommended for stroke prevention in AFib patients who have very good kidney function, defined as CRCL greater than 95 mmN.
Wait, not recommended if your kidneys work too well? Why?
It sounds counterintuitive, but the major clinical trial comparing edoxaban to warfarin in AFib found that in this specific subgroup with high creatinine clearance, edoxaban was associated with a higher rate of ischemic stroke compared to warfarin. So it was deemed less effective in that group.
That's really specific. So for all of them, regular monitoring isn't needed, but checking kidney function is important.
Exactly. For monitoring, like dabigatran, these factors inhibitors are given in fixed doses and do not require routine coagulation monitoring due to their predictable pharmacokinetics and pharmacodynamics. They do affect coagulation tests like the PT and, to a lesser extent, the APTT, but the effects are variable, and these tests are generally unreliable for monitoring efficacy or safety. Specific anti-factor assays with appropriate calibrators can be used to measure drug levels if absolutely necessary, but this is not routine practice. However, renal function should be assessed regularly, perhaps yearly or more often if clinically indicated, given the significant role of renal clearance for all of them.
Okay, and therapeutic uses. Similar to dabigatran.
Their therapeutic uses are broad and largely overlap with dabigatran: stroke prevention in non-valvular AFib, treatment of acute DVT-PE, and secondary prevention of VTE. A key difference in VTE treatment is that rivaroxaban and apixaban can be started immediately as monotherapy, often with a higher initial dose, whereas edoxaban, like dabigatran, typically requires an initial 5-10-day course of parenteral anticoagulation first. They are also used for postoperative thromboprophylaxis after hip or knee arthroplasty.
What about in cancer patients?
That's an important area. For cancer-associated VTE, DOACs, particularly edoxaban and rivaroxaban, have been shown to be at least as effective as LMWH, which was the standard, but may carry a higher risk of bleeding, especially in patients with intact gastrointestinal cancers. Apixaban might have a better balance here. Like dabigatran, these agents are generally contraindicated in patients with mechanical heart valves and are generally avoided in patients with antiphospholipid syndrome, where warfarin appears superior.
You mentioned dual pathway inhibition.
Yes, a fascinating development is dual pathway inhibition. Low-dose rivaroxaban, 2.5 milligrams twice daily, used in combination with low-dose aspirin, like 81 or 100 milligrams daily, is now licensed for the secondary prevention of major adverse cardiac and limb events in patients with chronic coronary artery disease or peripheral artery disease.
Combining an anticoagulant and an antiplatelet at low doses.
Exactly. This combination leverages a synergistic effect. The low-dose rivaroxaban attenuates thrombin generation and fibrin formation, while the low-dose aspirin attenuates platelet activation via TXA2 inhibition. Studies have shown this dual pathway approach is more effective than single pathway inhibition, like aspirin alone, in reducing major thrombotic events in these high-risk patients, albeit with an expected increase in bleeding.
Interesting strategy. What about side effects for the factor Zaganinu overall? Bleeding again.
Yes, in terms of adverse effects, as with all anticoagulants, the major concern is bleeding. A significant advantage, similar to dabigatran, is that the rates of intracranial bleeding with these drugs are consistently shown to be at least 50% lower than with warfarin. That's a major safety benefit.
Huge. What about other bleeding?
Rates of bleeding at other major sites, like GI, urinary tract, etc., are generally similar to or lower than warfarin, with a notable exception. GI bleeding tends to be higher with the once-daily regimens of rivaroxaban and edoxaban compared to warfarin, although this wasn't seen with twice-daily apixaban. This might be related to effects of unabsorbed drug on pre-existing lesions in the gut. Overall, though, life-threatening or fatal bleeding rates tend to be lower with DOACs compared to warfarin. Bleeding risk is, of course, increased with concomitant use of antiplatelets or NSAIDs.
And drug interactions for this class.
For drug interactions, all the oral factor inhibitors are substrates for the P-glycoprotein transporter, so PGP inhibitors can increase their concentration, and PGP inducers can decrease it. Additionally, rivaroxaban and apixaban are significantly metabolized by the hepatic enzyme CYP3A4. This means their levels are affected by strong CYP3A4 inhibitors like ketoconazole or tonavir, which increase concentrations, and strong CYP3A4 inducers like rifampin, carbamazepine, phenytoin, St. John's wort, which decrease concentrations and efficacy. Edoxaban undergoes minimal CYP3A4 metabolism, so it's less affected by inhibitors or inducers of that enzyme, but still affected by PGP modulators.
This is a crucial area of development, having specific antidotes or reversal agents for these newer direct oral anticoagulants. What options are available if serious bleeding occurs?
Yes, the availability of specific reversal agents for DOACs is indeed incredibly important for managing life-threatening or uncontrolled bleeding, or for patients requiring urgent surgery where rapid reversal is needed.
What do we have?
Well, for dabigatran, as we mentioned, we have idursulfimab. This is a specific reversal agent, a humanized monoclonal antibody fragment that binds to dabigatran with extremely high affinity, like 350 times higher than dabigatran's affinity for thrombin. It essentially forms an irreversible complex that's cleared by the kidneys. It's given as 2 intravenous boluses and provides rapid, complete, and sustained reversal of dabigatran's anticoagulant effects.
Okay, specific antidote for dabigatran. What about the factor XA inhibitors?
For the oral factor XA inhibitors, specifically FDA approved for reversing rivaroxaban and apixaban in cases of life-threatening or uncontrolled bleeding, we have andexanet alfa. It hasn't been evaluated specifically for pre-surgery reversal yet.
How does andexanet work?
It's quite clever. It's designed as a decoy for the oral factor XA inhibitors. It's basically a recombinant analog of human factor XAs, but it has been modified so it lacks catalytic activity and also lacks the GLA domain needed to assemble into the prothrombinase complex. So it circulates and binds up the factor XA inhibitor drugs, sequestering them away from the real factor XA.
Ah, a molecular sponge for the drug.
Exactly. It's administered as an intravenous bolus followed by a 2-hour infusion. It rapidly reverses the anti-factor XA's activity and restores thrombin generation. The dosing is different depending on which drug is being reversed and when the last dose was taken, with higher doses generally needed for rivaroxaban or edoxaban than for apixaban. It's quite expensive and often reserved for the most serious bleeds, particularly intracranial hemorrhage. One important note, it shouldn't be used if the patient also needs heparin, for example, during a procedure, as it might interfere.
Okay. Any others in development?
Yes, there's also siraparantag, which is currently in late-stage phase 3 clinical trials. This is a synthetic, small cationic molecule. Interestingly, it has been reported to bind not only dabigatran and the oral factor XA inhibitors, rivaroxaban, apixaban, edoxaban, but also unfractionated heparin and LMWH. It works by non-covalent hydrogen bonding and charge interactions. Early studies showed it restored clotting time rapidly in healthy volunteers given these anticoagulants. If approved, it could potentially be a broad-spectrum reversal agent.
That would be useful. What if these specific agents aren't available?
If specific agents like idursulfimab or andexanet alfa are unavailable or contraindicated, non-specific options like 4-factor prothrombin complex concentrate, PCC, can be considered to improve hemostasis by providing more clotting factors. Activated PCC, APCC or EFIBAR, or recombinant factor VIA might be alternatives, but carry their own risks.
Can dialysis help?
Dialysis can effectively remove dabigatran from circulation, especially in patients with acute renal failure because it's not highly protein-bound. However, dialysis is not effective for removing the factor AZ inhibitors, rivaroxaban, apixaban, or edoxaban because they are highly bound to plasma proteins and thus not readily dialysable. Hashtag defibrinolytic drugs.
Shifting gears, let's talk about drugs that actively break down clots, the fibrinolytic agents. These are often used in emergency situations where time is of the essence, right? The clot busters.
Exactly. These drugs are truly powerful agents used in emergencies like acute ischemic stroke, massive pulmonary embolism, or sometimes acute myocardial infarction if PCI isn't available. Fibrinolytic drugs work by initiating the fibrinolytic pathway, essentially by converting inactive plasminogen into active plasmin, which then digests the fibrin mesh of the clot.
What are the main ones used now?
The key examples in current use are recombinant tissue plasminogen activator, or TPA, specifically Alteplase, and its variants which have been engineered for longer half-lives, like Reteplase and Tenecteplase. Older agents like urokinase and streptokinase are rarely used or unavailable now in the U.S.
Let's focus on TPA Alteplase. How does it work?
Alteplase is a serine protease, basically a recombinant form of the natural TPA. Physiologically, it's actually a poor plasminogen activator when there's no fibrin present. But here's the key. When it binds to fibrin within a clot, its ability to activate fibrin-bound plasminogen increases several hundredfold compared to activating plasminogen freely circulating in the plasma.
So it's fibrin-specific, mostly activating on the clot.
Ideally, yes. This fibrin specificity helps localize plasmin generation to the site of the thrombus. However, at the high therapeutic infusion doses used, which result in plasma levels much higher than physiological levels, alteplase can overwhelm inhibitory mechanisms and induce a systemic to lytic state, leading to degradation of circulating fibrinogen and other clotting factors.
So high doses lose some specificity. How is it cleared?
Alteplase is rapidly cleared from the circulation, primarily by hepatic metabolism, with a very short half-life of only about 5 minutes. This necessitates administration, usually as an intravenous bolus, followed by an infusion for indications like coronary thrombolysis.
And the variants, retiplase and tecplase.
Yes, the variants like retiplase and tenecteplase were designed to have longer plasma half-lives. This allows for more convenient administration as 1 or 2 intravenous boluses rather than a prolonged infusion. Tenecteplase also has increased fibrin specificity and is more resistant to inhibition by PAI1. In clinical trials, they've shown similar efficacy and toxicity profiles compared to alteplase for indications like acute MI.
What's the main risk with these drugs?
The major concern with all thrombolytic agents is hemorrhagic toxicity. This is their primary toxicity and can be serious, even fatal.
Why does the bleeding happen?
It occurs for 2 main reasons. First, the generated plasmin degrades fibrin not just in the pathological thrombus you're targeting, but also in beneficial hemostatic plugs that might be present at other sites of recent vascular injury, like surgery sites or even minor unnoticed injuries. Second, the potential for a systemic haemolytic state, especially with higher doses or prolonged infusions, where systemic plasmin generation degrades circulating fibrinogen and other crucial coagulation factors, particularly factors V and 8. This severely impairs the blood's ability to clot anywhere.
Okay, breakdown of good clots and general impairment of clotting. How common is serious bleeding?
Serious bleeding occurs in maybe 2–4% of patients receiving these agents, especially if used concurrently with heparin. The most feared complication is intracranial hemorrhage, which occurs in up to 1% of patients and can be devastating.
That's significant.
It is. Because of the significant bleeding risk, mechanical reperfusion strategies like primary percutaneous coronary intervention, PCI, for acute MI with ST elevation, or mechanical thrombus extraction, thrombectomy, for acute ischemic stroke, often with or without adjunctive TPA, are now generally preferred over systemic thrombolysis when available and feasible within the appropriate time windows.
So physical removal is often safer if possible. Are there times you absolutely cannot use fibrinolytics?
Yes, there are strict contraindications to fibrinolytic therapy due to the bleeding risk. Absolute contraindications include things like any prior intracranial hemorrhage, a known structural cerebral vascular lesion, like an AVM, a known malignant intracranial neoplasm, ischemic stroke within the last 3 months, unless it's the acute stroke being treated within the 4.5-hour window, suspected aortic dissection, active bleeding, or unknown bleeding diathesis, excluding menses, or significant closed head or facial trauma within the past 3 months. There are also relative contraindications like severe uncontrolled hypertension, traumatic or prolonged CPR, or major surgery within 3 weeks, recent internal bleeding, non-compressible vascular punctures, prior exposure to streptokinase due to antibodies, pregnancy, active peptic ulcer, or current use of warfarin with an INR above 1.7. The decision always involves weighing the potential benefit against the significant risk of bleeding. #kitty. Inhibitors of fibrinolysis.
What if the problem isn't too little fibrinolysis, but too much? Do we have drugs to dial that back and prevent excessive clot breakdown, maybe in certain bleeding situations?
Yes, absolutely. We have drugs specifically designed to inhibit fibrinolysis, known as antifibrinolytic agents. The main ones are aminocaproic acid, EACA, and tranexamic acid, TXA.
How do they work?
Their mechanism involves acting as synthetic analogs of lysine. Plasminogen and plasmin normally bind to lysine residues on fibrin to exert their effect. EACA and TXA compete for these lysine binding sites on both plasminogen and plasmin. By blocking these sites, they effectively prevent plasmin from binding to fibrin, thus inhibiting fibrinolysis and stabilizing clots.
So they stop plasmin from attaching to the clot. What's the main concern with using them?
The main potential problem is that any thrombi that happen to form during treatment with these drugs might not be readily lysolized by the body's natural fibrinolytic system because you've inhibited it. For example, if a patient with hematuria, blood in the urine, forms clots in the ureter while on these drugs, the clots might not break down and could cause obstruction.
Okay, so you stabilize existing clots, but might prevent breakdown of new ones. Where are they used?
Their uses are quite specific. Aminocaproic acid has been used intravenously to reduce bleeding after certain surgeries, like prostatic surgery, and it can be given orally after tooth extractions in patients with hemophilia to prevent bleeding. It's absorbed rapidly orally, and about half is excreted unchanged in the urine. High doses rarely cause muscle problems.
And tranexamic acid. TXA seems more common now.
Yes, tranexamic acid, TXA, has gained much wider use. It's significantly more potent than EACA. It's given intravenously as part of trauma resuscitation protocols for patients with or at risk of significant hemorrhage, for managing massive obstetric hemorrhage like postpartum hemorrhage, and it's increasingly used to reduce operative blood loss in major surgeries like hip or knee arthroplasty and cardiac surgery.
Does TXA increase clot risk itself?
Studies suggest that when used appropriately in these settings, TXA has little or no increased risk of venous or arterial thrombosis, which is a key advantage. Like EACA, it's excreted primarily in the urine, so dose reduction is needed for renal impairment. Oral TXA is also approved for treating heavy menstrual bleeding. Hashtag F antiplatelet drugs.
Finally, let's explore drugs that target platelets, the very first responders to vessel injury. These are critical for preventing arterial thrombosis, which often involves platelet-rich clots, right? Like in heart attacks and strokes.
Absolutely. Platelets are indeed foundational to initial hemostasis, forming that primary plug, but they also contribute significantly to the development of pathological thrombi, particularly in high-flow arterial systems, leading to conditions like myocardial infarction, ischemic stroke, and peripheral arterial disease. In recent years, a variety of potent inhibitors of platelet function, or antiplatelet drugs, have been developed.
Different ways to stop platelets.
Yes, these drugs act by distinct mechanisms, targeting different activation pathways or the aggregation process itself. This is important because it means that when used in combination, their effects can be additive or even synergistic in inhibiting platelet function.
Okay, where should we start? Aspirin.
Let's start with the classic, aspirin. Its antiplatelet mechanism of action is remarkably precise and well understood. Aspirin irreversibly blocks the production of a key platelet activator, thromboxane A2, TXA2.
How does it block it?
It does this by acetylating a specific serine residue near the active site of the enzyme cyclooxygenase 1, COX1, within the platelet. COX1 is the enzyme responsible for the first step in synthesizing TXA2 from arachidonic acid.
Irreversibly acetylates COX1. And that's permanent for that platelet.
Yes, that's the key. Since platelets are enucleated cell fragments, they lack the machinery to synthesize new proteins. Therefore, the action of aspirin on platelet COX1 is permanent, lasting for the entire 7 to 10-day lifespan of the affected platelet. This means repeated daily doses of aspirin produce a cumulative effect on the overall platelet population's ability to produce TXA2.
So even low doses work over time. What's the optimal dose?
It's surprisingly low for the antiplatelet effect. Complete inactivation of platelet COX1 can be achieved with a daily dose as low as 75 milligrams. Studies have shown that aspirin is maximally effective as an antithrombotic agent at doses much lower than those required for its analgesic or anti-inflammatory effects, typically in the range of 50 to 325 milligrams per day.
Higher doses aren't better.
No, higher doses don't improve efficacy for thrombosis prevention. In fact, they might even be theoretically less efficacious by potentially inhibiting the production of prostacyclin, an anti-aggregatory substance, by endothelial cells, which can regenerate COX. Plus, higher doses definitely increase toxicity, especially bleeding and GI upset. Therefore, daily aspirin doses of 100 milligrams or less, often 75 milligrams or 81 milligram, are now standard for most cardiovascular prevention indications.
What about other NSAIDs like ibuprofen? Do they work the same way?
That's an important distinction. Most other NSAIDs, like ibuprofen or naproxen, are reversible inhibitors of COX1. Because their effect is temporary, they are not effective as antithrombotic agents. In fact, they might even interfere with the irreversible binding of low-dose aspirin if taken concurrently, potentially reducing aspirin's cardioprotective effect.
Okay, good to know. What's next after aspirin?
Next is dipyridamole. This drug interferes with platelet function by a different mechanism. It increases the intracellular concentration of cyclic AMP, CACT. High GAMP levels inhibit platelet activation.
How does it increase GMP?
It's thought to do this either by inhibiting phosphodiesterase enzymes, which normally break down GMP, or by blocking the cellular uptake of adenosine. Adenosine acts on A2 receptors on the platelet surface, which are linked to adenyl cyclase, the enzyme that makes CAMP. So blocking its uptake effectively increases adenosine's local concentration and stimulates CAMP production.
Okay, different target. Any other effects?
Yes. Dipyridamole is also a vasodilator. Clinically, it's used, though less commonly now, often in combination with warfarin to inhibit embolization from prosthetic heart valves. An extended release formulation combined with low-dose aspirin is approved for the secondary prevention of stroke.
Right. Now, the P2Y12 inhibitors sound important.
They are a major class, yes.
Yeah.
The P2Y12 receptor antagonists. Platelets have two main purinergic receptors that bind ADP, which is a key mediator released from dense granules upon platelet activation. These receptors are P2Y1 and P2Y12. The P2Y12 receptor is particularly crucial because when activated by ADP, it couples to an inhibitory G protein, leading to inhibition of adenyl cyclase, lower CMP levels, and potentiation of platelet activation and aggregation. So blocking this receptor is a powerful antiplatelet strategy.
Okay, blocking P2Y12 stops ADP from amplifying activation. Which drugs do this?
Let's start with ethenopyridines. The main one used now is clopidogrel. It largely replaced an older drug, taclopidine, due to better potency and much lower risk of serious side effects like neutropenia.
Clopidogrel, how does it work?
Clopidogrel is a phenopyridine prodrug. That means it's inactive as administered and needs to be metabolized in the liver to form its active metabolite. This active metabolite then irreversibly binds to and inhibits the P2Y12 receptor on platelets.
Prodrug needs activation, irreversible binding. What does that mean practically?
It means it has a relatively slow onset of action because it needs to be metabolized first. And because the binding is irreversible, the antiplatelet effect persists for the entire lifespan of the platelet, 7-10 days, resulting in a slow offset of action after stopping the drug.
And you mentioned CYP2C19 before with warfarin. Relevant here too.
Very relevant. The activation of clopidogrel relies heavily on the hepatic enzyme CYP2C19. As we discussed, there are common genetic polymorphisms in CYP2C19 that result in reduced enzyme activity. Patients who are poor metabolizers for CYP2C19 generate less of the active metabolite, leading to reduced platelet inhibition and potentially a higher risk of thrombotic events like stent thrombosis, despite taking clopidogrel. This highlights the issue of variable response.
So some people might not get the full benefit from clopidogrel due to their genes.
Exactly, which has led to interest in genetic testing or using alternative agents in some cases. In terms of therapeutic uses, clopidogrel has been shown to be better than aspirin alone for secondary prevention after ischemic stroke. Its combination with aspirin is superior to aspirin alone for reducing recurrent ischemia in unstable angina or NSTEMI. It's FDA approved to reduce the combined risk of stroke, MI, or vascular death in patients with recent MI, recent stroke, established peripheral artery disease, or acute coronary syndrome, ACS. It's routinely used, usually with aspirin, dual antiplatelet therapy, or DAPT, after coronary stent implantation to prevent stent thrombosis.
Standard after stents, what are the risks?
The main adverse effect, as expected, is an increased risk of bleeding, especially when combined with aspirin or an anticoagulant. Although rare, cases of thrombotic thrombocytopenic purpura, TTP, a serious clotting disorder, have been reported.
Syn interactions, the CYP2C19 thing again.
Yes, for drug interactions, the potential interaction with proton pump inhibitors, PPIs, particularly omeprazole and esomeprazole, which are potent inhibitors of CYP2C19, has been a concern. They might reduce the formation of the active metabolite, potentially lowering clopidogrel's efficacy, though the clinical significance remains debated. Conversely, CYP2C19 inducers could potentially increase exposure. Opioids can decrease exposure. And obviously, combining it with anticoagulants, NSAIDs, or even SSRIs increases bleeding risk. Caution is also advised with warfarin, as clopidogrel can potentially inhibit CYP2C9, warfarin's metabolizing enzyme.
Okay. Then there's prasugrel, another thenopyridine.
Yes, prasugrel is the newest member of the thenopyridine class available. Like clopidogrel, it's a prodrug that requires hepatic activation to an active metabolite that irreversibly inhibits P2Y12.
How is it different from clopidogrel?
Its activation process is generally more efficient and less dependent on CYP2C19 specifically. This results in a more rapid onset of action and, importantly, greater and more predictable inhibition of ADP-induced platelet aggregation compared to standard doses of clopidogrel. Like clopidogrel, its active metabolite binds irreversibly, so the effect lasts for the platelet's lifetime.
More potent, more predictable. How is it metabolized?
Regarding ADME, it's rapidly and completely absorbed from the gut, then quickly hydrolyzed and oxidized in the liver to the active thiol metabolite. A much higher percentage of absorbed prasugrel gets activated compared to clopidogrel, where only about 15% gets activated. It's then inactivated by other pathways. Moderate kidney or liver impairment doesn't seem to significantly change its effect.
Where is prasugrel used?
In terms of therapeutic uses, prasugrel is indicated, usually with aspirin, to reduce thrombotic cardiovascular events, including stent thrombosis, specifically in patients with acute coronary syndrome, ACS, who are managed with percutaneous coronary intervention, PCI. Major clinical trials showed it significantly lowered the incidence of the combined endpoint of CV death, non-fatal MI, or non-fatal stroke compared to clopidogrel, mainly driven by a reduction in non-fatal MI. It also significantly reduced rates of stent thrombosis.
Sounds better than clopidogrel then. Any catch?
The catch is bleeding. For adverse effects, prasugrel was associated with significantly higher rates of major bleeding, including fatal and life-threatening bleeding, compared to clopidogrel in those trials.
The efficacy-bleeding trade-off again.
Exactly. Due to a particularly high risk of intracranial bleeding observed in certain subgroups, prasugrel is contraindicated in patients with a history of prior stroke or transient ischemic attack, TIA. It's also generally not recommended or requires dose reduction in patients older than 75 years due to increased bleeding risk, or those with low body weight, less than 60 kilograms, where the dose is typically reduced to 5 milligrams daily after the loading dose. TTP has also been reported rarely. For serious bleeding, platelet transfusion might be beneficial, unlike with reversible inhibitors.
Okay, interactions.
For drug interactions, the main concern is additive bleeding risk with anticoagulants, SSRIs, or NSAIDs.
Moving on to ticagrelor. How is it different?
Ticagrelor is different from the thienopyridines. It belongs to a different chemical class, cyclopentyltriazolpyrimidines, and importantly, it's an orally active, reversible inhibitor of the P2Y12 receptor. It binds to a site distinct from the ADP binding site.
Reversible, that sounds like a key difference.
It is. This reversibility means it has a more rapid onset and offset of action compared to the irreversible inhibitors. Platelet function recovers faster after stopping the drug. It also tends to provide greater and more predictable inhibition of ADP-induced platelet aggregation than clopidogrel.
How is it handled by the body?
In terms of ADME, its oral bioavailability is around 36%. It can be crushed if needed. It's metabolized primarily by hepatic CYP3A4 to an active metabolite, which also contributes to the effect, and then further metabolized to inactive compounds. It's given twice daily.
So being reversible means its effect wears off faster, which might be an advantage if a patient needs emergency surgery.
Precisely. Its reversibility offers a quicker return towards normal platelet function after discontinuation, typically within a few days. In terms of therapeutic uses, ticagrelor with aspirin is FDA approved for reducing the risk of cardiovascular death, MI, and stroke in patients with acute coronary syndrome, ACS, or a history of MI. An important point is that it's indicated for ACS patients whether they are managed with PCI or managed medically, unlike prasugrel, which is primarily for PCI-managed patients.
Okay, broader ACS indication. What about side effects?
Its adverse effects include bleeding, of course. Like prasugrel, it was associated with a higher risk of non-CABG-related major bleeding compared to clopidogrel in its major trial. Interestingly, it was also associated with a higher risk of intracranial bleeding than clopidogrel. Due to this, it's contraindicated in patients with a history of prior intracranial bleeding. Another unique side effect is dyspnea, or shortness of breath, reported in about 14–17% of patients. This is usually mild and often transient, and not typically related to underlying pulmonary disease, but can be bothersome.
Dyspnea, that's unusual. How do you reverse bleeding?
That's a challenge with ticagrelor's reversibility. Because the drug is circulating and can bind to P2Y12 receptors on transfused platelets, platelet transfusion is likely ineffective for managing serious bleeding. However, there is a specific antibody fragment reversal agent, bentricimab, PB2452, currently under investigation that binds ticagrelor and its active metabolite.
Okay. Interactions. That's CYP3A4 metabolism.
Yes, drug interactions are important. Aspirin doses greater than 100 milligrams daily appear to reduce ticagrelor's effectiveness in its main trial, so maintenance aspirin doses should generally be kept to 100 milligrams or less. Because it's metabolized by CYP3A4, potent inhibitors like ketoconazole or strong inducers like rifampin should be avoided as they can significantly alter ticagrelor levels. Opioids can decrease its exposure. Ticagrelor itself can inhibit CYP3A4 and P-glycoprotein, potentially increasing levels of drugs like simvastatin or lovastatin and possibly digoxin.
Okay, one more P2Y12 inhibitor.
Cangrelor.
Yes, cangrelor. This one is different because it's a parenteral intravenous P2Y12 inhibitor. And like ticagrelor, it's a reversible inhibitor. It's an ATP analog. Intravenous and reversible.
Correct. It's rapidly dephosphorylated in the blood to an inactive metabolite, giving it a very short half-life, only about 3–6 minutes.
Very short acting.
Extremely. In terms of ADME, it's given as an IV bolus followed by an infusion. It inhibits ADP-induced platelet aggregation within minutes of starting the infusion, and platelet function returns to normal within about 1 hour of discontinuation.
Oh, rapid on, rapid off. Where is it used?
Its therapeutic use is as an adjunct to PCI to reduce the risk of periprocedural MI, repeat coronary revascularization, and stent thrombosis in patients undergoing PCI who have not been pretreated with an oral P2Y12 inhibitor and are not being given a GPI-EAI antagonist. It's basically for immediate, potent platelet inhibition during the procedure itself.
For PCI specifically, side effects.
The main adverse effect compared to control, often clopidogrel given later, is a higher risk of bleeding during the PCI procedure.
Makes sense. How does it interact with switching to oral agents?
That's a critical practical point regarding drug interactions when transitioning. Because cangrelor is reversible, ticagrelor, also reversible, can be given during or immediately after the cangrelor infusion. However, the irreversible prodrugs, prasugrel and clopidogrel, require binding to the P2Y12 receptor for their active metabolites to work. Cangrelor occupies this receptor. Therefore, loading doses of prasugrel or clopidogrel should only be administered after the cangrelor infusion has been stopped. Otherwise, cangrelor will block their binding and prevent them from working effectively.
Okay, timing matters for the irreversible ones. What about targeting thrombin's effect on platelets directly?
Good question. That brings us to thrombin receptor inhibitors, specifically PAR1 antagonists. As we discussed earlier, thrombin is a potent platelet activator. It does this primarily by cleaving and activating protease-activated receptors on the platelet surface. Humans have two main ones, PR1 and PR4.
PR1 and PR4.
Thrombin cleaves the extracellular domain of these receptors, creating a new N-terminus, which then acts as a tethered ligand, folding back to activate the receptor itself. PR1 is activated by lower concentrations of thrombin than PR4, making it a key target.
So block PR1.
Exactly. Vorapexar is an orally active, competitive antagonist of PR1. By blocking PR1, it inhibits thrombin-induced platelet aggregation, as well as aggregation induced by the PR1 activating peptide.
How is it taken and how long does it last?
Regarding ADME, it has high oral bioavailability, around 90%, and a rapid onset of action. Although its circulating half-life is about 3-4 days, its effect on platelet aggregation persists for up to 4 weeks after stopping the drug. This is because it binds very tightly, essentially pseudo-irreversibly, to the PR1 receptor. It's metabolized by CYP3A4.
Weeks. Wow. Where is it used?
Its therapeutic uses are quite specific. It's approved for oral administration, always in combination with either aspirin or clopidogrel, not as monotherapy, to reduce the risk of thrombotic cardiovascular events in patients with a history of myocardial infarction or those with peripheral artery disease, PAD.
Added on top of other antiplatelets. Risks.
The main adverse effect is, predictably, an increased risk of bleeding, including intracranial hemorrhage. Because of this, it's contraindicated in patients with any history of intracranial bleeding, stroke, or TIA.
Okay. Interactions.
For drug interactions, since it's metabolized by CYP3A4, potent inducers of CYP3A4, like rifampin, can significantly reduce its exposure, while strong inhibitors, like ketoconazole, can increase exposure. Antacids and pantoprazole might also reduce exposure slightly.
And finally, we have drugs that target the ultimate common pathway of platelet aggregation, the glycoprotein IBA inhibitors.
That's right. The final step where platelets actually link together. Glycoprotein I-beta, GPI-beta, also known as integrin I-beta, is a receptor found in very high numbers on the platelet surface. Normally, it's in an inactive state, but when platelets are activated by agonists like ADP, thrombin, or TXA2, intracellular signaling causes GPI-beta to undergo a conformational change.
What does the change do?
This change transforms it into a high-affinity receptor capable of binding fibrinogen and, to some extent, von Willebrand factor. These proteins, particularly fibrinogen with its dimeric structure, then act as molecular bridges, linking adjacent activated platelets together, leading to platelet aggregation and thrombus formation. So blocking this final step is a very potent way to inhibit aggregation, regardless of which agonist initiated the activation.
The final common pathway. Are these used much now?
Their use has definitely decreased somewhat with the advent of the more potent oral P2Y12 inhibitors like prasugrel and ticagrelor, but they still have a role primarily in high-risk PCI settings. There are 3 approved intravenous agents.
Okay, what are they?
First is abciximab. This is the Fab fragment of a humanized monoclonal antibody directed against the GPI-beta receptor. It also binds to the vitronectin receptor on platelets and endothelial cells.
An antibody fragment.
Yes. It's used as an adjunct to PCI, along with aspirin and heparin, to prevent acute cardiac ischemic complications like recurrent MI or death. Its circulating half-life is short, maybe 30 minutes, but because it binds so tightly to the receptor, its effect on platelet aggregation lasts for 18-24 hours after stopping the infusion.
Long effect. Risks.
The major side effect is bleeding, occurring in maybe 1–10% of patients, depending on the setting. Thrombocytopenia, low platelet count, can also occur in about 2% of patients. Sometimes it can cause pseudothrombocytopenia, an artifactual clumping in the lab tube. Readministration can be associated with the development of human anti-chimeric antibodies, which might increase the risk of thrombocytopenia or hypersensitivity reactions. For major bleeding, platelet transfusion may help reverse the aggregation defect since the antibody concentration falls relatively quickly.
Okay. Next.
Eptifibatide. This is a cyclic peptide inhibitor designed based on a sequence found in snake venom. It mimics a part of fibrinogen and competitively inhibits fibrinogen binding to the GPI-IEA receptor.
A peptide mimic.
Exactly. It's given intravenously, typically as a double bolus followed by an infusion during PCI, particularly in primary PCI for ST elevation MI, STEMI, or for unstable angionin STEMI patients undergoing PCI. It's cleared mainly by the kidneys and has a short plasma half-life, around 10–15 minutes, so its effect wears off relatively quickly after stopping the infusion. Bleeding is the major side effect. Thrombocytopenia can occur but seems less frequent than with abciximab, maybe 0.51%.
And the third one.
Tirofeban. This is a non-peptide small molecule inhibitor of GPI-BIA, also given intravenously. Like eptifibatide, it has a short duration of action. It's used primarily for patients with non-ST segment elevation acute coronary syndrome, NSTE-ACS. The dose needs to be reduced by half for patients with significant renal impairment, CRCO60-LLMIA. Again, the major side effect is bleeding, and it may also induce thrombocytopenia.
We've mentioned vitamin K's crucial role in the mechanism of warfarin, but it's a truly vital player in its own right in our body's intricate clotting system. Let's delve into its broader significance.
Indeed. Vitamin K is absolutely fundamental. Its primary known physiological function is acting as an essential cofactor for a unique enzyme, glutamyl carboxylase. This enzyme catalyzes the post-translational modification of multiple glutamate glue residues into gamma-carboxyglutamate glutyl residues on several critical proteins.
Which proteins need this GLA modification?
Most famously, the vitamin K-dependent clotting factors synthesized in the liver, factor 2, prothrombin, factor 7, factor IX, and factor X. But also importantly, the natural anticoagulant proteins C and S and protein Z.
So both pro-clotting and anti-clotting factors need it.
Yes, which underscores its role in maintaining balance. These glass residues are absolutely essential for the biological activity of these proteins. They act like calcium binding sites. Binding calcium allows these proteins to undergo a conformational change that enables them to interact properly with anionic phospholipid membranes, like those on activated platelets, which is critical for assembling the coagulation complexes like tenese and prothrombinase and efficient clotting.
Right, back to the docking onto the platelet surface.
Exactly. This carboxylation reaction is coupled with the oxidation of vitamin K hydroquinone to vitamin K epoxide. This occurs within the vitamin K cycle, primarily in the liver, but also in other tissues like lung and bone. For the cycle to continue, vitamin K epoxide must be reduced back to vitamin K quinone and then to the active hydroquinone form. The enzyme responsible for the epoxide reduction step is the vitamin K epoxide reductase complex subunit 1, VKRC1, the very enzyme inhibited by warfarin. Mutations in the glutamyl carboxylase enzyme itself can also cause rare bleeding disorders.
Okay, so the cycle keeps reduced vitamin K available. You mentioned bone.
Yes. Vitamin K also plays a role in bone metabolism. It's essential for the gamma carboxylation of certain bone proteins, like osteocalcin and matrix GLA protein. Some studies have linked vitamin K deficiency to decreased bone mineral density and increased fracture risk. Supplementation has shown some promise in improving carboxylation status and maybe bone density, but the overall relationship and clinical impact on fracture prevention remains somewhat unclear. Interestingly, long-term warfarin use doesn't seem to consistently change bone mineral density in adults, though it might affect new bone formation.
So vitamin K isn't just about clotting. It's involved in bone health, too. How many types of vitamin K are there, and what's the difference?
There are two main natural types of vitamin K with biological activity in humans. Vitamin K1, also known as phytonadione or phylloquinone, is the form derived primarily from plants, think leafy green vegetables. This is the only natural vitamin K form available for therapeutic use in the U.S.
K1 from plants.
Right. Then there's vitamin K2, which refers to a series of compounds called menaquinones. These have varying side chain lengths, designated MKN, like MK4, MK7. Menaquinones are synthesized mainly by bacteria, including the gram-positive bacteria that make up part of our normal intestinal flora. They are also found in some fermented foods and animal products.
K2 from bacteria and some foods.
Is one better? They have different absorption and distribution patterns. K1 is the primary dietary source. K2 forms might have longer half-lives and different tissue distributions, potentially playing a more significant role in tissues outside the liver, like bone and vasculature, but research is ongoing. There was also a synthetic form, menadione, sometimes called K3, but it's no longer used therapeutically due to toxicity concerns, especially hemolytic anemia and kernicterus in neonates.
How much do we need?
The human requirements for vitamin K are actually quite small, estimated perhaps between 0.03 to 1 microgram per kilogram per day. For an average adult, this translates to roughly 70 micrograms daily.
And if you don't get enough?
Deficiency. The major clinical manifestation of deficiency is, unsurprisingly, bleeding. This can manifest as easy bruising, ecchymosis, nosebleeds, epistaxis, blood in the urine, hematuria, gastrointestinal bleeding, excessive postoperative hemorrhage, or in severe cases, intracranial hemorrhage. Basically, impaired synthesis of functional clotting factors leads to a coagulopathy.
Is too much vitamin K toxic?
In terms of toxicity, the natural forms, fibrinolytic K1 and the menaquinones K2, are generally considered non-toxic, even at high doses. However, as mentioned, the synthetic menadione K3 can cause hemolytic anemia and liver toxicity, especially in newborns.
Okay. How is it absorbed and handled?
Regarding ADME, the absorption of the fat-soluble vitamin K compounds, K1 and K2, from the intestine requires the presence of bile salts and pancreatic juice, similar to other fat-soluble vitamins. Fibrinolytic K1 is absorbed primarily by an energy-dependent process in the small intestine, while menaquinones K2 seem to be absorbed more by diffusion in the distal small intestine and colon.
Eats bile salts like fat.
Yes. After absorption, fibrinolytic is incorporated into chylomicrons and transported via the lymphatics. It's taken up by the liver and concentrated there, but liver stores are relatively limited, and fibrinolytic levels decline rapidly if intake stops. The body only maintains modest stores of vitamin K overall compared to other fat-soluble vitamins.
What happens if you can't absorb fat properly?
That's a key cause of deficiency. Any condition that leads to malabsorption of fats or lack of bile reaching the intestine, like biliary obstruction or biliary casapula, will impair vitamin K absorption. This can lead to a progressive reduction in the plasma concentrations of the vitamin K-dependent clotting factors over several weeks, eventually resulting in hyperprothrombonemia and bleeding risk.
Okay, so when is vitamin K used therapeutically?
Therapeutic uses of vitamin K, specifically phytonadione, K1, are primarily focused on correcting bleeding tendencies or active hemorrhage associated with its deficiency. This deficiency can arise from several situations: inadequate intake, inadequate absorption, inadequate utilization by the liver, or as a direct consequence of vitamin K antagonist action, like warfarin overdose.
How is it given?
Administration can be oral, which is generally preferred when possible. For faster reversal of anticoagulation, such as with warfarin overdose, it can be given by slow intravenous infusion. However, rapid IV infusion carries a small but significant risk of severe anaphylaxis-like reactions, flushing, hypotension, cardiovascular collapse, so it must be given slowly and cautiously. Subcutaneous injection is generally avoided, especially in patients with coagulopathy, due to erratic absorption and risk of hematoma formation.
Let's break down the causes of deficiency needing treatment. Inadequate intake.
True dietary deficiency leading to inadequate intake is actually quite rare in healthy adults because vitamin K is present in many common foods, especially leafy greens, and it's also synthesized to some extent by our gut bacteria. However, patients on prolonged intravenous alimentation, TPN, without supplementation are at risk and typically require about 1 milligram of phytonadione per week. Also, prolonged use of broad-spectrum antibiotics can sometimes cause hypoprothrombonemia by eliminating the intestinal flare that produce vitamin K2.
Okay. What about newborns? You mentioned that before.
Yes, hypoprothrombonemia of the newborn leading to vitamin K deficiency bleeding, VKDB, is a significant concern. Healthy newborns naturally have decreased plasma concentrations of vitamin K-dependent factors for the first few days of life. This occurs in about 3% of live births if no prophylaxis is given. It's particularly associated with exclusive breastfeeding, as human milk contains very low levels of vitamin K, and the newborn gut hasn't yet established a robust vitamin K synthesizing microbiome. Commercial infant formulas are supplemented.
So what's done?
To prevent VKDB, routine administration of 1 milligram of phytonadione intramuscularly, IM, at birth is legally required and standard practice in the U.S. and many other countries. The dose might need to be increased if the mother was taking warfarin or certain anticonvulsants during pregnancy. Sometimes clinicians may treat mothers on anticonvulsants with oral vitamin K prior to delivery as well.
Okay, routine IM shot at birth. What about absorption problems?
Inadequate absorption is another common reason for deficiency requiring treatment. As we discussed, this occurs when bile fails to reach the intestine, like an obstructive jaundice or biliary fistula, or due to defective fat absorption from other causes. Bleeding associated with these conditions usually responds promptly to vitamin K administration. Oral route might require co-administration of bile salts, or parenteral route can be used. Malabsorption syndromes like cystic fibrosis, celiac disease, Crohn's disease, ulcerative colitis, chronic dysentery, or extensive bowel resection can also lead to deficiency, often compounded by concurrent antibiotic use.
And if the liver itself isn't working well?
That's inadequate utilization. Severe hepatocellular disease like advanced cirrhosis or hepatitis can lead to hypoprothrombonemia because the damaged liver cannot adequately synthesize the clotting factors, even if vitamin K is available. Long-standing biliary obstruction can also eventually impair liver function. In these cases, parenteral vitamin K, e.g. 10 milligrams daily, might help somewhat if inadequate bile secretion was also contributing, but if the liver damage is severe, the response may be poor. Paradoxically, giving very large doses of vitamin K to patients with severe liver disease might actually worsen liver function further.
Tricky situation. Lastly, drug-induced causes.
Yes, drug and venom-induced causes. Warfarin and its congeners are the classic example, acting as competitive antagonists of VKOR. Vitamin K is the direct antidote. Also, interestingly, bites from certain snakes, like the tropical American pit viper, can cause hypoprothrombonemia that responds to vitamin K treatment. Hashtag outro.
Wow. What a journey through the incredibly complex world of blood fluidity and the powerful agents that manage it. From the microscopic dance of platelets and coagulation factors to the nuanced mechanisms of our modern medications, it's clear this isn't just about thinning the blood, but a precisely orchestrated intervention.
Indeed. It really is remarkable. Understanding these intricate pathways and the specific actions of each drug, whether it's, an antiplatelet targeting initial plug formation, an anticoagulant attenuating fibrin, a fibrinolytic actively breaking down a clot, or even the vital role of vitamin K itself, truly highlights the marvel of physiological balance and the pharmacological precision required to master this field.
And it underscores that fine line, doesn't it, between preventing dangerous clots and avoiding potentially life-threatening bleeding. The side effects, the intricate drug interactions, the development of specific reversal agents for newer drugs, it's all part of what it takes to grasp this information like the elite professionals in the field, just as we aimed for in this deep dive.
Absolutely. And this raises an important question, I think, for you, the listener. Given the constant advancements we see in medicine, what do you think the next big breakthrough in managing blood fluidity might actually be?
Good question.
Will it be even more targeted therapies with perhaps fewer side effects? Maybe more personalized medicine based on individual genetics to predict responses to drugs like warfarin or even clopidogrel? Or perhaps entirely new approaches to influencing clot formation and dissolution that we haven't even conceived of yet?
A lot to consider, as always, and a testament to how deep we can go when we truly dive into the sources. We certainly hope this deep dive has given you a comprehensive and confident grasp of this fascinating and absolutely critical area of human health.
We hope so.
Until next time, keep exploring, keep questioning, and keep getting informed.